Today we're going to have a discussion on adult vaccinations. The immune response that can be provided through a vaccination comes in two forms, which is active and passive. Active is a way to stimulate the host to produce a primary immune response using a piece of a bacteria or a virus, whether it be live or attenuated or killed, or maybe just any kind of antigenic subunits of an organism. The other way is through passive immunization, which is the administration of antibodies from another individual that has undergone either the infection itself or a vaccine, and they produce the antibodies that we need to create an immune response in another using those antibodies. There are true contraindications when it comes to vaccines. A lot of patients will say that they have reactions to them, but sometimes those reactions aren't actually true contraindications. They're just a subjective reason that they don't want to get a vaccine. But the true contraindications are mostly anaphylaxis, maybe a systemic reaction to a vaccine or to the different ingredients within them, such as neomycin or streptomycin in MMR. And adults who are immunocompromised as a result of a disease or a treatment, you should avoid a live vaccine as there is risk of the virus replicating itself. In a household with immunocompromised patients, you should avoid oral polio because it is live and it can spread even though it is attenuated, but the MMR is okay to use. And in pregnant women, we should avoid all live vaccines because of the potential risk of crossing the placenta into the fetus and having risk for the fetus. We talked about what are true contraindications to vaccines, but now we'll talk about what are not contraindications to vaccines. So a current or recent mild illness with or without low-grade fever, using antibiotics currently or recently, a local reaction to a vaccine such as tenderness, redness, swelling, fever that is not like a major fever that is going to require hospitalization, or even a family history of adverse reactions to immunization. Some people will have parents who have actual contraindications such as penicillin allergies to penicillin, or they'll have anaphylaxis to certain vaccines, but those do not always and are not likely to transfer onto the children. So in this presentation, we'll talk about pneumonia, shingles, HPV, meningococcal, Tdap, and influenza vaccines. First is the pneumococcal vaccine. There's two types of vaccines. There's many types within those categories. There's a polysaccharide vaccines, that's the PPSV, and then there's the conjugate vaccines, which is the PCV. The conjugate vaccines seem to be better because they have they're linked to a protein which creates a better immune response. It seems that we're moving on to using more conjugate vaccines in the future. So who should receive the pneumococcal vaccine? So all adults equal or greater than 65, or if you're 19 to 64 with any pre-existing medical conditions that would increase your risk for meningitis, or if you are immunocompromised in any way. So they say cochlear implants, people with CHF leaks, especially people with asplenia, as pneumococcal is an encapsulated organism. People who are asplenic are at an especially increased risk for pneumococcal, and people who are cancer or HIV especially. So which vaccine should they get? Usually we've been giving now the Prevnar 20 or the PCV 15 and the PPSV 23. But if you've received the PCV 13 at any age or the PPSV 23 at 65 or greater, then just give the PCV 20 at this point in time. The next vaccine that we're going to talk about is the herpes zoster or the shingles vaccine. So it's caused by herpes zoster, or otherwise known as varicella zoster. It's a virus, and 30 to 40 people over 55 do not have a response. So we've been giving a recombinant vaccine called Shingrix, which is greater efficacy over the live vaccine, and we give that to immunocompetent individuals that are equal or greater than 50 years old, or people that are immunocompromised over 18 years old. So regarding which vaccine do we give, we usually give the recombinant vaccine. That's going to be a 2-dose vaccine, 2 to 6 months apart. Or we can give the live version of the vaccine with people who are allergic to the recombinant version or people who just won't receive the multiple doses. And what do you do if they've had shingles in the past? Well, you give it to them, but usually within 1 year after last infection, because it's said that they are usually covered from that last infection for about a year. The next vaccine we're going to talk about is for HPV, which is the human papillomavirus. In the past, we were giving the Gardasil 4. It covers for HPV 6, 11, 16, 18. But in recent years, we've now moved on to Gardasil 9, which covers now those 4 in the past, plus 31, 33, 45, 52, and 58, which are now other high-risk HPV strains that we're trying to cover for. So we give those to people who are ages 11 to 12, but we can also give it as early as 8 to 9 years old. Usually we try to give it early, but if we can't, 13 to 26 is fine. And right now, ages that are over 26 aren't really recommended. So for HPV, there's 2 age categories, less than 15 and over 15. So for less than 15, the immune responses are stronger. So 2 doses of HPV given at day 0 and then 6 to 12 months afterwards usually provides a good enough immune response. And then people who are over 15 years old usually will receive 3 doses, and those are going to be at 0 the first shot, and then 2 months later, and then 6 months after that first shot. If you miss a dose, just continue where you left off. There's no reason to start over from scratch. The next vaccine is for meningococcus. It covers Neisseria meningitidis. It comes in 2 forms. There's a quadrivalent vaccine that covers the A, C, W, and Y strains, and there's also the serogroup B strain. The serogroup B strain is more high risk, and it's given to everyone that's 16 to 23 years old. They get the serogroup B vaccine. And then when it comes to people who are a higher risk for Neisseria meningitidis, such as people who have traveled to exposed locations, who are microbiologists who work with Neisseria meningitidis, people that are in close quarters with other people, and then people with immunodeficiency that have a C5 deficiency or taking an inhibitor of any kind. The meningococcal vaccine schedule is a little complicated because there's 2 different types of vaccine, the MenB and the ACWY. In the unvaccinated immunocompromised, we give a 2-dose schedule at least 2 months apart, and then a booster every 5 years. If there's an outbreak of meningitis, usually receive the MenB. It's going to be 0 months, 2 months, and then 6 months apart from the first dose. Age 19 to 21 who did not receive a dose by age 16 should be given a single dose of the Men-ACWY, even if they received it at age 11 to 12. And then everyone under age 22 should have a documented dose of the meningitis ACWY at least 5 years before enrollment in college. And usually we give that around 16 to 18 years old. And then it's also recommended perhaps that the 16 to 23-year-olds should have a serogroup B vaccine, the MenB vaccine. Next we'll talk about the Tdap vaccine. This is a painting depicting tetanus, classic case of diphtheria, and this is pertussis. So with Tdap, there are 2 different options. There's the TD and the Tdap. The Tdap contains the acellular pertussis. So every 10 years after a complete immunization schedule as a child, you should be given a dose, or right when you turn 18 if you have not received the Tdap previously. If you're not vaccinated, you get 3 vaccines, usually just Tdap all the way, and that's at 0, 4, and 6 months, 6 to 12 months after that. And then we also receive the Tdap after an acute injury or wound, and we'll talk about that on the next slide. So there's 2 types of wounds, either clean and minor or dirty and bad. So we'll start over here with clean and minor. So we ask the patient or see if they've had the records for their childhood vaccinations, and if they have, then we find out if they've had a Tdap or TD dose within the last 10 years. If they have, then you're okay, and you just go along the the vaccine schedule as planned. If they haven't, then you just give them a single dose of the tetanus vaccine right there. And if they haven't, then you just start the age-appropriate the tetanus vaccine. Regarding the dirty wounds, it's a little more complicated, but not too bad. And dirty wounds would be dirty like with soil, feces, saliva, or dirt, or really deep wounds with like a rusty nail or anything like that. So just like with the clean wound, we're going to check to see if they've had their childhood vaccines, and if they have, we see if they have the last dose in 5 years versus 10, and if they have, then they're okay for now. You just start back on the 10-year plan. But if they have not received one within the last 5 years, then you just give them a single dose that day. When there's one more thing we could do, which is give the tetanus immunoglobulin, and we do that when we don't know the vaccine status and it's a really dirty wound, or if we know that they have not had their childhood vaccines. And in that case, we would go this direction, the algorithm, and we would give them the immunoglobulin plus the tetanus vaccine, and then we would try to get them on to complete the course of the vaccine to get them protected. The next vaccine we're going to talk about is for influenza. There's a new flu vaccine every year due to antigenic drift. They check the previous season of antigen to see if they can try to guess the next strain that's going to be prominent within the United States. There are a few different types of vaccines. There's the inactivated, recombinant, and live vaccine. Each different vaccine will contain a few different strains of the flu. So who should receive the influenza vaccine? That's pretty much everybody, and it's given annually during the flu season between September and April. And as you can see here, it says less than 50, we give inactivated. Immunosuppression and pregnancy, we give inactivated. 50 to 64, we give inactivated. And then over 64, we give inactivated. So pretty much everyone's getting inactivated in the United States. Next, we'll talk about vaccines in pregnancy. So regarding vaccines in pregnancy, we want to ideally give the patients before they get pregnant vaccines. The MMR can be given up to 28 days before conception, and after delivery, all vaccines that cannot be given in pregnancy should be given. So during pregnancy, we do give 2 vaccines particularly, and that's the influenza vaccine and the Tdap vaccine. All pregnant women will receive a single dose of the Tdap between 27 and 36 weeks, and with each pregnancy, and the influenza vaccine as well. So there are certain special circumstances regarding pregnancy and vaccinations. We don't always give the pneumococcal vaccine and the Haemophilus influenza, meningococcal, Hep A, Hep B, yellow fever, poliovirus, typhoid, and rabies, but we do worry about the risks versus the benefits during pregnancy. If the patients seem to be at high risk for their area, or they're traveling to a place where these things are going, then maybe we will consider giving these vaccines. But in general, we try to avoid them. And then specifically, we avoid live or live attenuated vaccines such as the MMR, the HPV, the tuberculosis, and the chickenpox vaccines, and the live influenza vaccines. There's some special populations that need to be addressed regarding vaccines, and that's people who have solid organ transplants, sickle cell disease, and HIV. Solid organ transplants, usually we want to vaccinate early before they get a transplant. After the transplant, we normally wait 3 to 12 months until proper immunosuppression is attained. Sometimes we give the immunomodulatory therapy, such as like anti-CD20 antibody, but we do give influenza about 1 month after the transplant is done. For sickle cell disease, they have impaired splenic function, which puts them at risk for encapsulated organisms such as strep pneumonia, H. flu type B, and Neisseria meningitis, meningococcus. So we try to vaccinate them early and often. And for HIV, live vaccines, if their CD4 count is over 200 cells per microliter, and we also want to give them herpes zoster vaccine if they're over 17 years old. So some more populations. It's going to include chronic liver disease and rheumatoid diseases. So regardless of the type of chronic liver disease, whether it be Hep C or non-alcoholic fatty liver disease, they normally have impaired splenic function, and they should be treated same as a sickle cell patient regarding the vaccine schedule for them. And regarding rheumatoidal diseases, usually they're going to receive rituximab, and that's going to have an effect on the humoral immunity, which is our strongest type of immunity. So prior to immunosuppression, we want to give the inactivated vaccines. We can give that up to 2 weeks before the immunosuppression, or live vaccines about a month before the immunosuppression. And after immunosuppression, we usually wait about 3 months to 6 months after the final dose. So people that are traveling, sometimes they'll receive special vaccines depending on the location that they're traveling. The CDC every year will update the website that is going to tell you the high-risk vaccines that should be taken before going to certain locations. So other than the common vaccines that we normally take, that we've been talking about, there are vaccines for Hep A, yellow fever, cholera, Japanese encephalitis, rabies, and tick-borne encephalitis. And those would be given depending on the location that you're traveling to. Now we'll talk about some reasons for vaccine hesitancy and how to answer questions for patients. So some common reasons for vaccine hesitancy would be cultural pressures, unwanted side effects. They have plans that they don't want to have these unwanted side effects. Maybe they're misinformed about the effects or the reasons for having the vaccines. Maybe that they had a family member in the past who had adverse reaction and they don't want to have that. Maybe they had adverse reaction themselves, or maybe they just have untrust of doctors, government, and pharmaceutical companies in general. So regarding vaccine hesitancy, what should we do? So we just remain calm, ask questions about why they don't want the vaccine, have a mutual discussion with the patient, answer the questions, give recommendations, and move on. Though the vaccine is the patient's choice, and we can only give recommendations whether they want to take them or not. We're not going to be the ones to force vaccines onto patients. Now we'll have some questions to test your knowledge regarding the vaccinations. So here we have a 56-year-old male with a past medical history of hypertension, diabetes, and hyperlipidemia. He presents to your clinic complaining of a burning, painful rash to his right mid-back, as seen on the picture below, which began 3 days ago. His vitals are stable, and after discussing the diagnosis and treatment with him, he asked if there's anything he can do in the future to prevent this from happening again, as it is one of the worst things he's ever experienced. What is your response? So you can pause the video now, but we'll go over the discussion if you'd like. So this is a case of shingles. You can see that it's in a dermatomal pattern on this person's mid-lower back. The answer here would be there's a vaccine that we can give which decreases the likelihood of getting this again, and that's going to be the Shingrix vaccine. Next question we have is a 25-year-old female, G2P2001, at 29 weeks gestation, presents for a routine prenatal checkup on a cool autumn day. She has a history of a short interval pregnancy with 13 months between pregnancies. She received full prenatal care during her last pregnancy, but has not received any vaccinations during this pregnancy. Her vital signs are stable. Which vaccine should this patient receive at this visit? Pause now if you want to answer for yourself. So in this patient, she had a previous pregnancy 13 months ago, in which she very likely received the Tdap and the inactivated influenza vaccine at that time. So for every pregnancy that we have, we give the Tdap for each pregnancy between 26 and 37 weeks. And in this case, it's a cool autumn day, so we're going to give the inactivated influenza as well, so the answer is going to be B. The last question we have here is about a 66-year-old patient who received a 15-valent pneumococcal conjugate vaccine 1 year ago. Which one of the following pneumococcal immunizations is recommended for this patient? Pause now if you'd like. So this patient should receive a 23-valent pneumococcal vaccine, the Pneumovax 23, because you received that one after the 15 at the age of 65. Here's some sources for you. And thanks to everyone for listening. Appreciate you.